Good morning, everyone. Li Jie here. I'm an infection control nurse from Singapore Changi General Hospital. COVID-19 pandemic is still ongoing now. I hope everyone is well and safe. Today, I would like to share something regarding COVID-19. A novel virus emerged in December 2019 has caused severe pneumonia among some patients. It was named as severe acute respiratory syndrome coronavirus 2, in short SARS-CoV-2. The disease was designated as COVID-19 by WHO in 2020. Person-to-person transmission of SARS-CoV-2 is most likely through respiratory particles. The highest risk is associated with close proximity to an infected person. The transmission of infectious fomites by touching contaminated surface is also possible. The early data has shown heavy contamination of patient rooms with SARS-CoV-2. Laboratory experiments also shows SARS-CoV-2 remains viable up to 28 days in controlled lab environments. SARS-CoV-2 can remain viable for long times. It also depends on the type of surface they stay on. In my hospital, there are 2 COVID-19 wards. One ward has isolation rooms with negative pressures. Another ward is a cohorted ward. Each patient room is 4 bedded. The current cleaning practice in my hospital is we firstly clean with the hospital-approved disinfectant. Then will be disinfected again with a 1000 ppm bleach solution. This is being carried out 3 times per day. What challenge we are facing right now? The general ward cleaning standard had dropped from our monthly environmental cleaning on days. This is likely due to higher workload was required in COVID-19 wards. This has caused increased CPCIE cross-transmission in a few general wards. It's very difficult for us to recruit more housekeeping staff due to the border control. Therefore, I need to review our current cleaning practice to ensure staff safety in COVID-19 wards, also at the same time to ensure patient safety in other general wards, also in long time to ensure its sustainability. So my question will be, is there real-life data to qualify the risk of SARS-CoV-2 transmission from environmental services? If there is, how does this data may support practical guidelines for environmental cleaning? Therefore, today my general sharing will be detection and infectivity of SARS-CoV-2 environmental contamination in isolation units and quarantine facilities. This study was carried out in Israel. It has published in Clinical Microbiology and Infection in 2020. The study of the background is the extent of transmission of SARS-CoV-2 by indirect contact through contaminated surface remains undetermined. Coronavirus remains viable on surface for a prolonged period of time, but it's all under controlled laboratory conditions. Studies have demonstrated surface contamination by SARS-CoV-2 RNA only. This positive viral RNA PCR tests do not approve viral viability. Therefore, this research aims to firstly investigate the stability of SARS-CoV-2 on smooth, non-porous surface under controlled environment. Secondly, to assess the environmental contamination, viability, and infectivity of SARS-CoV-2 in the surrounding of COVID-19 patients in hospital isolation units and quarantine hotels. The study method, SARS-CoV-2 strain MUC-IMB1 strain was used for the laboratory testing. Plastic and metal coupons were inoculated with SARS-CoV-2 virus first. Then the coupon was kept under controlled temperatures and 50% relative humidity. The virus viability was determined by Veron E6 cell cultures. Studies was carried out in 2 COVID-19 isolation units from 2 different hospitals and 1 quarantine facility. In Hospital A isolation units, there are 28 beds. Each patient rooms can take 1 to 3 patients. Patients having mild to moderate disease. No patient were ventilated at the time. In Hospital B isolation units, 40 beds there. Each patient room has 1 to 6 patients. Patients having more severe disease, some patients were ventilated. In the quarantine facility, is a hotel. Each room takes 1 patient or a family. Most patients are asymptomatic. What are the standard practice in each area? In both hospital A and B, the staff wearing full PPE when looking after COVID patients. It includes isolation gown, face shield, mask, shoe cover, and caps. While in hospital A, they wear 1 pair of gloves at a time. It had to be changed when leaving each patient's bed. While in hospital B, they wear 2 pairs of gloves. It's often not changed during patient care. The cleaning was performed twice a day in both hospital A and B with 1000 ppm bleach solution, while cleaning was done once a day in quarantine facility in the common area only. For the size of sample surface area is 20 × 20 cm. If it is a small object, will be swabbed entirely. During the swab collection, 2 wet swabs and 1 dry swab will be used. Then the 3 swab will be put into a 50 ml tube. It contains 2 ml transfer media. The real-time RT-PCR assay was performed using a 1-step kit from BioLine. Again, the virus infectivity was tested on around E6 cells. Let's look at the results. Under the control temperature in the laboratory, at 22 degrees, the virus on both plastic and metal coupons was undetectable on day 4. You can see by 24 hours, a 3.5 log reduction was observed on plastic coupon, while on the metal coupon, after 6 hours, a 4 log reduction was achieved. When the temperature was increased to 40 degrees to 50 degrees, after 30 minutes, the 2 log reduction was observed. When the temperature goes up to 60 to 70 degrees, after 10 to 20 minutes, no variable particles was detectable. How about in the hospital setting? In the non-ventilated patient rooms, 43% of the surface were contaminated with viral RNA. It was detected on the patient's floors, bedside tables, or some of the patient's personal items as well. While in the ventilated patient rooms, 72% of the surface were contaminated with viral RNA. Again, it was found on patients' bed rails, ventilator touch screens, also some computer accessory used by staffs. Again, also on the water tap handles. In hospital A, 26% of surface were found contaminated. The average cycle threshold or the CT value was 38, while in hospital B, it was much more contaminated, 72%. The average CT value is similar, 34. The difference between the 2 hospital level contamination might be due to the patient's presence of symptoms, the stage also illness, also whether the patient was ventilated. Again, the practice in the 2 hospitals is different. Remember, hospital B, they wear 2 pairs of gloves, then they do not change between patient care. This will affect the contamination of patient environment. A study shows environmental surfaces are more contaminated in week 1 of illness. However, in this study, they did not mention the stage of patient illness. Overall, in both hospital A and B, 51% of surfaces are contaminated. However, no viable virus was found from any of the samples. But some missing information here. What is the patient's room temperature and the humidity? Also, the sample collecting time was not mentioned in this study at all. It's important to take the patient's room temperature, as under the lab environment, as shows increasing temperature will reduce the survivability of the virus. In the quarantine facility, the overall positive rate was 38%. Public area was slightly more contaminated than hotel room. Again, there's no viable virus was detected in any of the surface. In summary, the result shows SARS-CoV-2 remains viable up to 3 days at 22 degrees under a controlled laboratory environment. The decay of viral viability correlated with the increasing temperature. Nearly half of the COVID-19 patient room surrounding environment are contaminated with SARS-CoV-2 RNA. However, no viable virus was detected from any of the samples. So the study concluded prolonged viability of SARS-CoV-2 in controlled conditions. This is supported by other studies as well. They could not isolate viable SARS-CoV-2 in hospital environment. To me, this is a very new finding, as a very limited study on viability of SARS-CoV-2 in a hospital setting. Most of the study have done on environmental contamination, but to detect SARS-CoV-2 RNA only. There's some limitation in this study. The sample was collected at a single point of time, did not monitor the environmental contamination for individual patients over the course of illness. Definitely some missing data information here, like patient profile, patient illness profile, whether do they have any symptoms, the stage of illness, lastly, the environmental factors, what is the patient room's temperature and humidity. The effect of virus strain is unknown as well. It's likely a single virus strain in the hospital, but was not specified in this study. Again, the time of sample collection was not mentioned in this study, whether it's collected before or after cleaning. This study is important as it has assessed the viability of virus in both lab environment and the real-life clinical setting. It has demonstrated positive viral RNA does not determine the viability of virus. The validity of the study. It has shown a robust experiment here from the way they collect the sample and the testing method. For the external validity, as the isolation unit setting unknown here, like what's the ventilation in the isolation units and the space. Patient population unknown as well, like the stage of illness, symptoms of patients. Therefore, it cannot be generalized to other healthcare settings, a bigger population. How this study applicable to a wider population? They could not isolate viable SARS-CoV-2 in hospital setting. This is a very important finding. So we should ask ourselves, have we focused on too much on environmental cleaning for COVID-19 wards? We can clean more frequently in COVID-19 wards, but this has caused unnecessary exposure of our housekeeping staff to the risk of COVID-19 due to the study limitation. Further study definitely will be needed. To study on more sampling points over a longer duration, more variables to be collected to provided, also a control study to compare routine cleaning versus enhanced cleaning in COVID-19 wards. The relevance to our general club participants here, this study has shown positive viral RNA detection for environment does not prove virus viability for environmental services. Hospital environmental services in COVID-19 wards are heavily contaminated with viral RNA. However, no viable virus was isolated in this study from the environment. Therefore, in healthcare setting, infection control should still focus on staff protection from wearing appropriate PPE to reduce direct face-to-face transmission with droplet aerosol protection. More data to better define the risk of environmental acquisition are required in future. In conclusion, from the study finding and the limitation, I would like to maintain the current cleaning protocol in my hospital. But again, I need to balance the work between COVID-19 wards and other general wards. Definitely, I will explore more further research studies on COVID-19 ward environmental contamination. Thank you for your time. Here is my reference.